Can you hear us? Can you see us? Let us know on chat if you can hear us, if you can see us. And in a few minutes, we will start the webinar. Perfectly. Okay, you can hear. Okay. Okay, so just a minute, just to wait for the people and we can begin. Hello. Nice to read you too. Okay. Okay. I think we will not wait longer. Who is with us? It is, and maybe somebody will join in a few minutes. Okay, just let me know the last thing. Do you see the slides and the presentation? Okay, you can see. Okay, thank you. So let's begin our webinar. Don't waste our time. So again, hello everyone. First of all, we are really pleased to welcome you here on this webinar, and we are really pleased to launch this international webinar on the fundamentals of 5 regulatory systems concept and Pinotherapy. So the method created by a Polish orthopedist, Polish medical doctor, Radosław Składowski. The method is gaining its popularity in Poland, and we teach our students, and we have also students from abroad. And sometimes we get questions about the method, about the English version of our materials, of our courses, and that's why we decided to organize and launch this webinar. So my name is Krzysztof Skibiński, and with my friend and instructor Jakub Łamajkowski, we will lead you, we will guide you through this webinar together. So what is our plan? Let's begin with the plan. So the most important information, I think that it may be the most important for you, that the webinar will be recorded. So there will be it will be possible to watch the retransmission. We will share it on our YouTube channel. So don't worry if you are from another time zone or you are busy right now or anything. It will be possible to rewatch the webinar as many times as you want. The whole webinar will take about 2 hours and a half. I know it's quite long, but we decided to tell you about every each of the basics of all 5 regulatory systems. So for sure we will take one short break in the middle of the webinar. So what are we going to do? Of course, we are going to introduce the concept, the history of the concept, the history and the author of the method, of course. Then you should know what actually is this mystical regulatory system, and then the main part of the webinar, so the description, the short description of a theory, the techniques and the patients according to every each of 5 regulators, a short discussion or short small talk about diagnosis, about our inner system of diagnosing patients, and of course the summary of the webinar. If you will have any questions, please ask your questions when you just want to do it. I mean, don't wait till the end of the webinar. I think we should do it by the time. It will be easier for us to answer in the context. And after 2 hours and a half, I suppose that everyone may be a bit tired. So just ask us if you want to, and we'll try to follow the chat and the question. And if you want to share this webinar on your Facebook, Instagram, anything, add something to your story. So please remember to tag us on social media, just like Kinga asked you on the chat. So let's start. Let's start with the introduction. The introduction of Radek Składowski. Radek Składowski is, like I said, he's a medical doctor. He is an orthopedist, and he studied in the 90s in Poland, in Wrocław, and then after becoming a medical doctor, he moved back to his hometown called Kędzierzyn-Koźle, and there he started practicing as a doctor. After a few years, he became an orthopedist, and this is actually when the history starts. Because, of course, as every each orthopedic surgeon, he was working in the operating room, but he was also working in outpatient clinic with his patients. And in this outpatient clinic, he recognized that the patient often came with very various problems, and those problems, as you probably know, they were surprisingly often they didn't fit into the diagnostic frameworks and the principles we know from the medical textbooks, from the researchers sometimes. So I suppose that all of you know that the reality of working with the patient is a bit different than the books and being at university and listening to the lecture, and that's why Radek also had some problems with difficult patients with locomotor system dysfunctions. So he started asking questions, and the main question was, and actually till today it is a question, why when we have patients with a dysfunction, let's say sciatica, let's call it, or a disc root conflict, why does it happen that they have the same diagnosis but different pain? For example, the localization may be different. Okay, so we have patients with diagnosed sciatica who complain of the pain around the whole leg, and sometimes we have patients with diagnosed sciatica or disc root conflict when they feel the pain only, for example, in their buttock. And this is not the end, because the next question is why patients, while having the same diagnosis, they claim that the pain occurs and goes down in totally different movements, different positions. So for example, we can have a patient who tells us that he has his sciatica, and the longer I walk, the worse pain I feel. So walking makes the pain worse, makes the pain higher. And we can have opposite patient with sciatica who will tell us that the longer I walk, it is better. So I feel the highest pain during my standing position or lying position, and it's radiating through the whole lower limb. But when I take a walk or something like this, I will move myself. The pain is gone. So the same diagnosis, but totally different clinical situation and clinical symptoms with the patients. So maybe there's not only one diagnosis, we should give two different diagnoses to those two patients. These are questions that Radek asked himself, and actually he still asks. So while searching for the solutions for his patients, Radek recognized that working in the operating room and surgeries and pharmacology, this is not everything. He recognized that with this difficult patients, with difficult problems in the locomotor system, he wanted to dig deeper, to learn something more to treat those patients. And that's how Radek became a manual therapist. He learned manual therapy body, manipulations of the joint, mobilizations of the joints, instrumental assisted techniques such as dry needling or pinotherapy, we will talk about. So many manual and instrumental assisted techniques to help patients in their way to health. And after 20, now we have at least 30 years after a series of observations regarding the therapy. After this series, Radek came to an idea of the basis of something we call five regulatory systems concept. And what is it? What exactly is the concept, and what does it mean, the regulatory system? This is a very important point of the speech and of the webinar. I would really like you to understand us clearly, so you can even note it down that there is no such entity as regulatory system. I mean, something like this doesn't exist. What Radek Składowski did was the regulatory system, or shorter, the regulator, is an idea, is a proposition. How can we try to understand our body, our locomotor system, musculoskeletal system disorders? So this is an idea where Radek connected certain tissues of our body with the certain physiological and pathophysiological processes. So we have a tissue, we have a physiological or pathophysiological process. And then he described the characteristics of objective pain syndromes. And those pain syndromes are linked with each tissue and its physiology. I know that it may sound complicated, but here we have a definition. So just let me just read it. So the regulatory system, or shorter, simply regulator, we mean is a set of a physiological processes connected, like I said, directly or indirectly to certain tissues in the body. These tissues can create a specific measurable pain symptom, and for each regulator, so for each tissue and the physiological processes, there's a matching therapeutic technique we want to use on our patient, technique or techniques. And this is very planned, very strict, very targeted intervention, and we of course aim to get a specific tissue, and our goal is of course removing the patient's symptom, which are measurable. And this is how those five regulators, five regulatory systems look like. So take a short look that the first regulator is just a story about the fascia, about the musculoskeletal system as we know it in a totally classical way. So we have muscles, we have fascia, we have ligaments, tendons, the attachments of muscles, the attachments of tendons. In the second regulator, we discuss about the flow of the fluids, the arterial blood, venous blood, lymph and interstitial fluid, and we discuss what will happen when the flow of the fluid is disturbed in our tissues. The third regulator, autonomic nervous system. So we discuss the situations when we have a disbalance between the sympathetic and parasympathetic activity, and what kind of symptoms, what kind of pain symptoms and other symptoms can patients have. And we work mostly on the level of subcutaneous tissue as therapists with the structures we call lipodynias. We will explain it, of course, later. The fourth regulator, the synkinetic one, it tells us more about the global approach to the human locomotor system. So observing of global movement patterns, analyzing the synchronization of different muscle group working with each other. So very global approach to the human's locomotor system. And the fifth regulator, reactive, connected with something we call SPA, so skin projective areas. This is the most difficult to explain to you. We will take it in the very end of the webinar. It tells us about those. It tells us a bit about the emotions of the patients, a bit about the psychosomatic aspect of our patients, but not only. We have a few observations we would like to share with you. And very shortly, there's a lot of literature we are basing on during this webinar, during our courses. So if you'll be interested in any subject from this webinar, probably I can send you much more details and literature about the phenomenons we will discuss here. So if you will be interested, feel free just to ask us. And the last few words of the introduction. So we know what's the story of the concept. We know what is the regulatory system, but what uh, what is the concept exactly? So what do we do in the concept? In the concept, in five regulatory systems concept, we use a lot of different methods of working with patient, and there are five main groups of techniques. Of course, Pinotherapy, so the therapy where we use tools. We use very simple tools, pins and cuts. We will describe it to you later. Manipulations and mobilizations, so very typical work with the joints. Abdominal therapy, which may be known by you as visceral therapy, so working with the abdominal cavity, with the internal organs, of course, in a very specific way, but helping our patients also by working with the abdominal cavity, its muscles. The fourth one, it's dry needling. We use a lot of dry needling technique, but one detail, this is a bit different than the classical way of thinking about the needling the trigger points. The therapy of the trigger points, I think it's very good, and you I think should do this. But in this concept, we try sometimes to do different needle techniques. We needle more, we put more needles. Sometimes we needle the ligaments, the attachments of the muscles, the attachments of the tendons. So it's a bit different type of a dry needling technique. And synkinetic issues connected, like I said before, with the synkinetic fourth regulator. So this global assessment and global working with the function of whole locomotor system. We will describe it later. And the last few words in the beginning. So, what with the diagnosis? And this is the next very important moment. What I would like you to know that, first of all, we must emphasize that in the method and in this webinar, we discuss professional medical care that should be provided to patients only under proper qualifications. So, therefore, before we start diagnosing by our using our inner system of diagnosing patient, we have to do all classical medicine. So we always diagnose and treat patients according to our competencies, whether you are a physiotherapist, a medical doctor, a chiropractor, osteopath, manual therapist. Of course, it depends on the country you work in. And of course, we treat patients according to the current standards of treatment and rehabilitation. And so we use functional tests. We examine the range of motion, and we assess pain of the patient. We use many scales. We do orthopedic testing. We do neurological testing. Everything, the criteria of inclusion and exclusion. So we do all of classical medical assessment and examination. And after this part, if we decide as a professionals that we want to work with these patients using manual therapy and instrumental assisted therapy, then we can switch to our inner system of diagnosing patients. We will explain it through the webinar, but we wanted you to just to take a short look that in FRSc we try to base on three basic levels. So the first is palpation. So we always do a lot of manual examination of the patient, and we always want to exactly to know where we do the therapy, what kind of tissues, is it safe or is something dangerous in this area. So this is very important for us to palpate and to examine the patient by our hands. The second one, the label pain. This is the very strong core of the concept. What does it mean? In each regulatory system, we will try to ask a question, when do you feel pain? And in different pathologies from different regulatory systems, we can have a bit different answer from the patient, and it will be very, very important. So you can remember, we always ask, when do you feel the pain? And the typology, we will not pay attention on typology during this webinar, but this is the additional tool just to characterize patients, to characterize them better, and to be more precise in our therapy strategy. And the last words, and I will give, and Kuba will continue, because I didn't introduce, I haven't introduced us yet. So both of us, me and Kuba, we are the instructors of the method. We practice in our clinics, in our offices. So we do a lot of work with the patients, and except of that, we also teach our students during a courses of pinotherapy, manual medicine, dry needling, manipulations, mobilizations. So we work a lot with patients, and also we work a lot with our students day by day. And this is all if it's going about the beginning. And now it's time to go to the first regulator. And Kuba, if you can hear us, and if you we
Yes,
can
I
hear
hear
you.
you. Thank
Okay,
you
we can
for
hear you.
great.
You can.
Yes, thank you for the great intro. So let's get to the business and let's go to the first regulator. So the first regulator is named Piezoactive structures and tissues. So the piezo comes from Greek and means to press. So when we are talking about the first regulator, is closely related to the fascia. We can say more broadly to the connective tissue. This system, we can say that the system responds for all mechanical overloads that our body is exposed to, and as well to process of adaptation to this load. So that's why in this context, we also, in the first regulator, we also refer to biomechanics and also refer to fundamental of the physics, because in this regulator is primarily about the function of the movement. So we can say, we can say that our body is in a constant state of adaptation to the different mechanical stresses, and this adaptation always be expressed within a connective tissue. So we know that the connective tissue has a number of functions, but we on this webinar and always on the Pinotherapy, we always focus on two of them: the support function and the receptive function. the support function, the support function is role is express an adaptation that increase low-bearing capacity of given structure and give us chances to taking big forces and mechanical stresses without any injuries. And the receptors function, we know that the connective tissue has a lot of receptors, and we'll be speaking about this soon. So let's take focus about the support function. Within the support function, we can distinguish probably the first one will be the trusses. And the trusses are very interesting structures because we are when you are looking at the slide about the trusses, we are have some structures that the elements of the structures are readily connected. It's very important. They are readily connected. So like the bridge of train or particular elements of the roof. If they're readily connected, so the main function of the trusses is getting one big forces and translate into smaller one. Within this smaller one will be spread out for the trusses, and that's why the trusses will be increasing low bearing capacity. So it will be expressed in increase to mechanical overloads. So if we give an example of the trusses, we're looking at the tuberculous structure of the bone, because the tuberculous structure of the bone is a good example of the trusses. And when we are looking on the left, on the picture of the left, this is a microscopic picture of the bone, and we are see that tuberculous structure of the bone are readily connected. Why they readily connected? Because that tuberculum bone is arranged in that way that the stronger the specific elements of bone that is we can say exposed to axial forces. There be tuberculum bone in this place where the axial forces acting, they are rebuilt to increase low bearing capacity. So on the right side, we will see the lines on the bone, and these lines show us how the tuberculum structure bone is arranged. Next one we can say, but trusses and tensegrity structures. Tensegrity structures are another important adaptation of connective tissue in our body. In this case, when we are looking on the structures, we have rich elements are alternately connective with tensile elements, created system in which stability emerges from interaction of those components. So if we saying about this example of tensegrity, I always say that example of tensegrity will be the places where the gradually changes their consistency along their courses. For example, if you have a muscle belly and muscle belly run into the tendon, and for example, tendon attachment to the bone. In our body, every place which is changing their consistency will be creating tensegrity structures. If you go into the next slide, we have an example of tensegrity. On the right side, we have some examples of the trusses. This is the medial region of the elbow, and we see the connective tissue lying on that and create the trusses and increasing low bearing capacity on this moment. And the left side, we see the structure of tensegrity. So we have a ridge element, we have a portion of the muscles, we have a connective tissue between them, and it will always create the tensegrity structure. So we have in FRSc, we have a lot of dissection, and we have some movie from dissections. This movie from dissections show us how how it looks in integrity. So this is the region of the lumbar spine, something between L4 and L5. This is the part of the on the bottom. We will see the fat, and this up we will see the particular part of the muscle. And when we are pulling upwards the surgical tool, we will see the whole connective tissue move as one unit, demonstrating as well as integrity. I hope this you will see of this presentation. Okay. Next one. Next one is a very interesting thing, because this is another adaptation. It's called the collar beam. Sorry. Collar beam is it's a term taken from the carpentry, because when you are looking at the particular parts of this roof, the collar beam is at a black one crossbar connecting to the particular parts of this roof. So and the main function of this black one cross beam is stabilizing particular parts of the roof. So we will see that the particular parts of the roof are readily connected. They have a common attachment and two different. So Radek start thinking about this, maybe it's analogy in the human body. So he's starting looking and observed something similar, like something similar. So it called we call this a collar beam. So collar beam will be condensation of connecting tissue, usually found within the intermuscular septa between two muscles, or two segments of portion of muscles, who has a common attachment, and two separate. So we can say that collar beam is a form of adaptation to mechanical overload, and will be located between two muscles. So main role of this collar beam is to stabilize pair of muscles performing, and this is very important, one repetitive move in one plane. So the collar beam will be stabilization part of the muscle, and antagonistic muscle can reduce energy cost from antagonic muscles. So collar beams will be giving stabilization during the one repetitive movement in one direction, one plane. So but if collar beam something gives, then the collar beam will be taken away, and will be influenced for work across different timings and the plane of the motion. So the patient will be can make the one movement in one direction, but if he will be want to use his muscles in different directions and different timing, he can enable to, because the collar beam, the second function of the collar beam, as if this condensation of the collar beam is good innervated with proper nociceptors. So if the patient will be want to use his muscles in a different timing in the different place, collar beam will be tucked, and then when will be tucked, then it will be annoying, and then will be have a pain, and the range of movement will be range of movement will be not good enough for this patient, so will be restricted. So the main function, we know that the function of the collar beam is stabilization of those muscles, but we can't make the movement with the different timings and the different range of motion and the different plays. This is most important to thinking about the collar beam. So the examples of the color beam, there are a lot of examples, because we must know that the color beam is probably our physiology. So when it's our physiology, so everybody has a color beam in his body. So when you are looking at the pictures of the dissections, so we're looking at the color beam always creating something like the letter A. So they have muscles have the really common attachment and two difference. So on the first one we see the muscles, the common attachment on the left, and the connective tissue between those two muscles. Here is a lot portion of the muscles, and big connective tissue between them, and it creates the color beam. On the next slide, we have some front deltoideus and pectoralis major. This is the region of the chest, and the connective tissue between those two muscles creating color beam. So another example of the color beam, we have some kind of the caput brevis, caput longum of the biceps, and here between those two heads we have some connective tissue, and we call this color beam. Next one, this is hamstring muscles. We have some semimembranosus, biceps femoris, caput longum, and the finger is under the color beam. This is a lot of connective tissue out there, so we see that's big structures. We have some movie from dissections from Madrid, and we'll see that this Radosław Składowski is preparing this cadaver. So this is the region on the up. We'll see the region of the gluteus. This is sacral bone, and see of the muscle of adductors, and we'll see the muscle of adductors, and this is a lot of the portion of the muscles, and between of them we will see the connective tissue, and the connective tissue creates the structure we call the color beam. So we observe in our body a lot of structures from first regulator, and there's very important, sometimes very important, the treatment this patient, because we don't know yet how it's pain in first regulator, but this is probably our physiological. So okay, this next one. This is not from our dissections. This is from medical, from internet. We can say from internet. So this is the semitendinosus. This is the gastrocnemius, and we have connective tissue right there, and it creates color beam between semitendinosus and gastrocnemius. C2 in the left, on the right, we have some gracilis muscle, semimembranosus, and connective tissue between them is also create color beam. So we observe another support function in the connective tissue, but in this webinar we don't have enough time to speak about it, so I will go to receptive hypothesis, because we must know what probably caused the pain, why it's pain this patient. We know that in receptive we have four major receptors, and the four major receptors we have interfacial mechanoreceptors, Golgi, Pacini, Ruffini, and interstitial. So this is tape 1, tape 2, and tape 3 and 4. So Golgi is located on these receptors are located in the tendon. Golgi will be activated when we getting a probably strong stretching with isometric tension, and when we go to the our range of motion. So to end of our range of motion will be feel the pain, and when we are on the end of range of motion, and we are in isometric stretching, the Golgi will be activated, and Golgi will give us a decrease in muscle tone, and when we have a decrease in muscle tone, our range of movement will be better. Tape 2A and tape 2B. Tape 2A, it's Vater-Pacini receptors. They activated when we have a sudden change in pressure and vibration. So these receptors, they don't decrease the muscle tone, but they stimulated proprioceptors in stimulated area. Then the proprioceptors are getting more sensitivity, and in the feedback, proprioceptors decrease the muscle tone. Ruffini receptors. Ruffini receptors, they like gentle work. A gentle work, like I don't know, some kind of approach in the osteopathy, like the craniosacral therapy, or for example, petting from massage. Yes. So the patient like these receptors, like the gentle work. And what this mean? If I gentle the work with these receptors, my inhibition of activity of sympathetic branch is getting lower. As in autonomic nervous system, I activate the parasympathetic and I decrease the muscle tone. The patient feels the better. And last one, 3-on-4 type, free nerve endings. Not only nociceptive receptors, but we have several receptors. They are thermal, chemical, and most important for us from the Pinotherapy, because in the first regulator, I must say that we always using the tools, cut, pins, and try needling is a good one. So mechanical for us, from the point of the Pinotherapy, the mechanical receptors are most important, because the mechanical receptors are sensitive for the pressure. And when we putting the tool onto the skin, to the tissue, we acting a lot of pressure. So we are annoying these mechanical receptors. And what if you are annoying the mechanical receptors, we give the patient, and this area is in pathology. The point is the pathology. The connective tissue is in pathology. Patient will be feel stinging, sharping pain. And what's happened if you put this tool to our body? We get the patient always feel the pain. So always feel the pain. They say this burning, cutting, and what we are doing, we are increase sympathetic branch, but we holding as long as we are overstimulated the sympathetic branch, and we are activated the parasympathetic branch, and this increase the muscle tone. We must remember that connective tissue, these points will be the same before therapy and after therapy. These pins on the stools, nothing's rebooting, nothing released there. We only acting on the physiological. We are knowing the receptors in connective tissue, and the connective tissue, nothing changes. There are no release. This is very important to know, because in Poland sometimes we say that we using the pins and we release the connective tissue. This is not true. This is now how the physiology working. So we are only using physiology, and we are only using the receptors, and we stimulate these receptors in connective tissue. And this is the diagram, shows that 18% of the receptors are 3 or 4 type. Yeah, so only 20% is the Golgi, Pacini, and Ruffini. So so this tells us how is the potential how is the big potential in using pin in these tools in this regulation. So we have a movie from the techniques. Sorry, this is the diagram. The Christopher likes the diagram. I must have spoken about them. So we have an excessive muscle tone, irritation of the nociceptors. Sorry, in connective tissue we have a pain. Under this line we have some therapeutic procedure. So we using the tools, make the therapy and reduce the muscle tone. Yeah, and the patient is happy. Everybody is happy. So the techniques on this slide we have two techniques: cut and out. So this is a base of compression of stimulation of mechanoreceptors. We are using these techniques, especially in the first regulator. Not only those two techniques, but we have several techniques. But this is the most basics and one time most important for us for treating this, for treating the patient. So that's why in the first regulator is named piezo. It's mean, if I told on the beginning, the piezo means from the Greek, it means to press. So because we are getting high pressure on the tissue. So the main question, the pain diagnosis. So how, when use this tool, when you're thinking about the pain in the first regulator. So the pain in first regulator is the most important to remember is that we have the pain. Well, the pain is well located. The pain will be quickly stopping and provoking movement. And this is for me is the most important. Is a resistant muscle pump. We cannot work it out. The patient will be not making the move which cause the pain because the pain will always be shows in special range of movements. So the patient cannot be worked out, and pain is well located. And when the patient is going with his range of motion to a specific range, they will have a cutting the movement. So the patient cutting the movement, so the patient cannot be cannot have the full of the range of movement. But during the therapy, this is also important. During the therapy, this point will be more intensive in the points surrounding it. Patient will be feeling burn, stabbing, cutting, gradually passing, pain, really radiating. This point's not radiating. If they radiating, we probably make mistake with a diagnostic assumption, and we make the therapy make therapy from another regulator. So we'll be speaking about this soon. So to sum it this, pain in first regulator is well located, quickly stopping, and when we provoke the moving, and we can't work it out, this pain. Because the muscle pump is resistant. The pain is resistant to muscle pump. We have two movies from the office. This is a movie from our instructor Olga. This shows how works one techniques. Techniques cut. The patient has a problem with his lumbar spine. He's showing where he's feel the pain. So the pain is well located. Yeah, the flex on the front is very pure. This patient is not moving very well. Yeah, will be side flexes. Also, is not good enough. The patient will see the patient is suffering because it hurts. And after one technique, so our friends make the kite, and from this one technique we see two lines across the lumbar, and in one techniques can changes a lot with the symptoms of the patients. Yeah, we always say this is not finish. We not finish the therapy. This patient needs another approach, another techniques, but we want to show how one techniques can change symptoms of the symptoms of the patient. So this patient, we call this patient type 1, the earth, but it's hard to translate in English because I thought this. I think it's better sound this type 1, the patient soil, like a ground. Because I think about when I'm speaking the earth, I think of the Captain America. I don't know why. So this is from this webinar. This is all from first regulator. Maybe we make the 5 minutes break, Christopher.
It's been 50 minutes, so maybe let's do a little bit of
5 minutes
second
breaks.
regulator, and then yes, we will make a short break. Okay, so just to sum it up, in the first regulator, we speak mostly about the classical locomotor system, about the fascia, about the receptors, and everything Kuba told you about. Of course, in a big shortcut. It takes us even half a day to discuss this subject with our students. But now it's time for the second regulatory system, humoral one. So, in the very beginning, in the second regulatory system, we talk mainly about the circulation of the fluids in the human body. So we have arterial blood, we have venous blood, we have lymph, and we have interstitial fluid. And now I would ask a question to you, very simple question, and I usually do it during the courses. So, have you ever seen in your whole life a swollen ankle after a sprain? Simple question. I suppose that the answer is yes. Probably everybody has seen the swollen ankle after the sprain. So, from the perspective, from the point of view of five regulators, we could call the swollen ankle after the sprain as a pathology of the second regulatory system. So now you can see I'm trying to show you that we can translate the regulatory systems for just the general medicine. So remembering this sprained ankle, we can say that the pathology in the second regulatory system, we can begin with pathologies. The source of a pathology is a disturbance of the fluid flow, either the outflow or the flow into the given area. So we will be looking for the places, for anatomical places in our body where there is a disturbance in the blood flow. And each area, each section, when we can find this disturbance of fluid flow, we can call it compartment. And it is exactly the same idea how in the very common, very popular, very known syndrome called in traumatology chronic compartment syndrome. I suppose you know this. It's not even a disease; it's very acute syndrome. In compartment syndrome, we know that there is not much space for the muscles in their facial septum, let's call it, facial compartment, and patient starts to feel pain. The pressure in the compartment gets higher. Patient feels pain, and of course we treat it by using a fasciotomy. So we have to cut the fascia to release the compartment to take the pressure down, and this is a very serious condition. In our office, in our practice, we don't speak about so serious conditions. We rather meet something different. And this is what I would like to start with. So, the muscle compartment called myoglossus. Uh, this is one of the most important for compartments for us, so that's why I would like to focus on it. So, Myoglosis is a very old term proposed by German scientists, and you may not know it because nowadays we rather know myoglosis as the hypertonic muscle spindles. Sometimes we can read in scientific literature, especially according to the trigger points, that the authors call those structures tight bands, taut bands, and like I said, sometimes hypertonic muscle spindles. Uh, anyway, it means that we have the part of the muscle which is very highly contracted. It is usually the answer for the bad posture of the patients, bad the movement patterns, or working style. I mean, a sitting position in work or something. Anyway, we have a part of the muscle which is very, very highly contracted. And what happens next? This is quite complicated process, and I will not describe it in details. But in general, inside the compartment, inside the space of the compartment, we have a contracted muscle spindles, and after this we can have the disturbance of the outflow of the venous blood. So because of the contraction, the venous blood has problems with getting out from the muscle, from the compartment, so it stays within the compartment. There are many biochemical reactions happening there. For example, the compartments, it gets very acid environment because of the venous blood. Uh, at all, we have contracted muscle, we have a venous blood staying in the compartment, so the pressure gets higher and our patient can feel the pain. Actually, this is the idea of this is a myoglosis in a very big shortcut. On the slide, you can see the pictures from scientific literatures, especially it is the same like with the color beams. So you can see the myoglosis here, and you can see what is the difference between those muscle cells and those cells here. The difference is that here you can see everyone when you can see everywhere when you can see the blue color, you can see the healthy muscle spindles with the water inside the cells. This is the white color. And where in the place where we have a compartment, so myoglosis, we can see very, because of the contraction of the muscles, the water got squeezed out of the cells. That's why we can see this manifestation of the contraction of the muscle, and the same we can see here. So you can compare the healthy muscle spindles compartment and what can happen after the pathology, after the chronic contraction of the muscle spindles. And the same you can see here in this pink one. Again, the A is the healthy muscle tissue, and here on the right side you can see contracted muscle spindles, so compartments, and the same below. So if you want to see how how want to remind how you can feel it on yourself, just find the most tender and tight muscle spindles on your upper trapezius. Everybody has one myoglosis here, so you can easily find it. And like I said, we're looking for the trigger point around the myoglosis. In our concept, in the method of Radek Składowski, we try to look for the myoglosis, so for the compartments, the muscle compartments. We have some maps. This is a very practical part of the course. So we have to we have to skip it, but we look for the myoglosis in the whole human muscle system, actually. And what now? how can we treat the patients who feels the pain, the patient who feels the pain from compartments from myogalosis. There are many different ways, but it's not very complicated, because I said that during working with the active myogalosis, the hyper tender muscle spindles, we have a high tension, and we have a high pressure in the compartment because of this venous blood staying inside the compartment. So what can we do? We have to, first of all, we have to release the tension, and then we have to restore the blood circulation and the outflow of the venous blood. So how can we do it? I'm sure that you know many techniques to release the muscle tension and to restore the proper circulation. So what we do in the method is looking for the tissue restrictions. So this is the first regulator, that something Kuba told you about. So we look for the adaptations of fascia, we look for the tension, and we try to restore the tension of the facial elements and musculoskeletal elements, just to restore the proper blood flow. Regulating disturbed chains. This is something connected with the fourth regulatory system, so I will speak about it later. But you can imagine that sometimes our patient can have chronic higher tension in any area of his body, because of wrong posture or the wrong training patterns, movement patterns. So the chronic tension and the myogalosis in some area of our body can be caused by chronically wrong patterns. And like I said, facilitating venous and lymphatic drainage. We use a lot of techniques. We use a soft tissue techniques. We use a dry needling. We dry needle the myogalosis, and we also use the tools, so pins and cuts, exactly the same like in the first regulator. Sometimes we also use a Humoral, so the therapy using the leeches. And now, again, the most important thing, so the pain diagnosis. The pain diagnosis, just a short reminder, in the first regulator, we speak about the irritation of nerve endings. So patients feels the pain which is well localized. Patient feels the pain which is rather not radiating, and during the active movement, patient feels in some moment that the pain started because of the irritation of mechanoreceptors, the type 3 and 4. In the second regulatory system, this is a bit different case, because here, first of all, the pain is not well localized. So it's not like in the first regulator that patient will show us the exact point from where the pain comes from, but will show us the area. So we will hear that I have a shoulder pain, I have a knee pain, I have a pain of my whole forearm, for example, because the compartment has a space to exist, to be present. So, very aerial pain, and this is the most important thing, the pain appears after stagnation during initiation of a movement. So, my patient says that while I'm sitting or lying, I feel okay, I don't feel any pain. But after a longer period of time spent in the one position, so for example, I'm sitting 5 hours in my office, or I'm lying on the couch for 3 hours because I'm watching TV. And after the stagnation, when I try to initiate the movement, I feel big pain in some area. Okay. And what is even more important, patient will tell us, should tell us, that the pain, it goes down during the movement. So I have a stagnation. So the compartments builds. Okay, so there is more disturbance in blood outflow from the compartment. So when I activate the muscle pump, so the pressure in the compartment gets higher, I feel the pain. But after few minutes of muscle pump working, so I went for a walk or something like this, I feel that the pain goes down. And there are many examples of patients, and we are sure that you know those patients who say that I have problem, I can feel the pain, but only in the morning. During the day, it's okay, but my lumbar spine feels terrible after the night. I'm getting back. I can't get up from my bed in the morning because I feel so much pain, but after a few movements it's a bit better, and after a few next movements it's even better and better, and after an amount of time, let's say 30 minutes, sometimes it's 30 minutes, sometimes it may take an hour, I don't feel pain and I can live normally. But next day in the morning I will feel again the same pain. Another example, the drivers who know that after a few hours of driving it is impossible to get out of the car without the pain, and they know that sometimes they have to make a short break for a walk. The IT workers, the office workers. So the summary is that we cannot, those patients should move a lot just to pump the compartment, just to pump those uh, edemas, let's call them. And this is only something, this is the addition, that of course not only the blood flow or the fluid flow can be disturbed not only in the muscles. Of course there are many more anatomical areas or structures where we can have the compartment problems and problems with the distribution of the fluid. So we can say about the ligaments, especially big ligaments like sacrotuberous ligament, iliofemoral ligament, ligamenta flava. It's a very interesting thing. Sometimes you can read on the description of the MRI of your patients that there's something like hypertrophy of ligamentum flavum. And so this hypertrophy of the ligament is maybe connected with the disturbance of the outflow of the fluid from the spinal column. Joint cavities, this is very classical thing. So I said sprained ankle, or I don't know, a knee after the surgery, it will be swollen. So it's also a kind of a compartment, but maybe not the compartment we want to work with the tools. Okay, we don't want to work with the tools and painful therapy one day after the surgery of the knee. Muscles, like I said, myogallosis, restrictive scars. We know that the scars can cause the problems with fluid circulation. Internal organs also, this is something more into the visceral therapy, so not for now for us. And neuro compartments, and this is the last example I would like to show you. What can be a neuro compartment? It's still a compartment created from a part of the muscle. So we have a myogallosis. So again, part of the muscle with a very big tension and the disturbance of venous blood outflow. And unfortunately, this myogallosis creates itself, sounds weird, but let's call it, happens in the area which lies very near to the any of peripheral nerves. So we have a muscle, we have a big tension of a part of a muscle, and we have a peripheral nerve in nearby. And this is a situation when we can have a classical conflict between the muscle and the nerve. So, what my patient can feel? First of all, they still feel the symptoms, the classical symptoms from the second regulatory system. So this one we discussed a few minutes ago. So patient complains of these factors of pain, and additionally patient can tell us that he or she feels any neurological dysfunctions. Rather, we say about very small dysfunctions. They can say that in the morning they feel back pain and a bit of numbness, of tingling in their thigh or in their foot, something like this. Usually it's not very, very, very high, but patient can feel it, and you can hear it from your patient. So the pain may be radiating because of the irritation of the peripheral nerve. The irritation of the peripheral nerve is mechanical, so the conflict between the nerve and the muscle, but also because of the structure anatomists call nervi nervorum. This is a structure described in 19th century, and these are small, very, very small nerve fibers which leave the peripheral nerve, penetrate to the soft tissue, and those fibers are ended with a nociceptor. So the high tensed muscle can irritate the nociceptors of nervi nervorum, which are within the muscle. You can see the nervi nervorum here. This is this small black line here. Here is the nerve, and we can see that the fiber leaves the nerve and goes to penetrate the muscle, the soft tissue around. So my patient feels pain, and there are many, many cadaveric and anatomical evidences for this kind of situations. There are many publications where anatomists describe the places, the anatomical areas where the peripheral nerves are close, very close to the different structures. And this is the job of anatomists, and this is all. But for us, we have to find what kind of clinical implications it gives us. And for us, neurocompartments, so the conflicts between the soft tissue and the peripheral nerve. And please take a look at the cadaveric pictures. Here you can see the ulnar nerve here, which is held, and we can see the triceps brachii muscle, its medial head, and we can see how the ulnar nerve is going into the medial part of the triceps brachii. Here you can see that after putting off the nerve, you can see that actually we barely can see where is the border between the muscle and the nerve. So now imagine that in this place here, the medial part of the triceps uh, gets very, very, very contracted. Okay, so this is a very good situation to create the neurocompartment, so the conflict between the contracted medial part of triceps and ulnar nerve. This is the one example. The second example, what we can see here, it's a posterior part of the knee joint. Here we can see the two heads of gastrocnemius muscle and the nerve, the tibial nerve, which is going which is going through the heads of the gastrocnemius. Please take a look at the middle picture. In the middle picture, we can see how the tibial nerve is getting surrounded by the connective tissue. So it's getting tighter there and goes into the head of gastrocnemius. And then we know from anatomy it goes down to the soleus muscle. And now please take a look at this picture. In this picture, we can see the anatomical picture of the gastrocnemius, of course. What we can see during the tension of gastrocnemius on the human, we can see the lateral head of the gastrocnemius, here lateral head. We can see the medial head, and we can see sometimes the massif of plantaris muscle on the lateral side. And please take a look at this picture here with our beautiful model. And here you can see the lateral part of the gastrocnemius, the medial part of the gastrocnemius, the massif of plantaris muscle here, like here in this anatomical drawing. Okay, so on the lateral side, and neural compartment and myoglossus is something we can see here. So this is practically part of the gastrocnemius muscle medial head, but as you can see, it's much more tensed than the rest of the medial head. And if you look again at this picture, and you will remember about this middle picture with the tibial nerve, the connective tissue, and the gastrocnemius. Now imagine the high tension in this area, the myoglossus, very high tension. So this is a situation when also we have a conflict between the muscle and the nerve. So patients feel pain like in the second regulatory system, and additionally, patient feels any kind of symptoms like tingling, numbness, neurological symptoms at all. What we want to do with that? Very simple thing. Just like I said, we want to use the techniques that gives more blood flow, more blood circulation, and releasing the muscle contraction, muscle hypertension, just to reduce this muscle tone and break the pain loop. And this is how we work. We have few neural compartments. We teach our students how to. We teach our students how to do it. Of course, it's not a time to teach you how to work with the neural compartments, but the techniques are very easy. So again, the examples of the techniques, we can use also both. We can use the instrumental techniques, instrumental assisted. We can use the manual techniques just to release the tension and make a better outflow of the blood. So these are an examples. And there are patients who have many additional factors that they like to take water to themselves, so they have a lot of compartments, and that's why we sometimes call those patients water or type 2. But we will remember that the names like earth, the water, this is only a technique just to communicate to each other, not with the patient. This is just a shortcut to communicate between the therapists. Okay, so this is the regulator 2, so the fluids, and now the third regulatory system, so the autonomic nervous system. We have exactly 17 past 8, so I think we can do a short break. Let's do a 5-6 minutes break, okay, and we will continue 3 more regulators, and we will be done with our webinar. If you have any questions, you can write it down on the chat. So let's have a break till 8:25. Let's
Okay.
say, and we will get back to the slides.
Okay.
Okay. So we will begin in a few seconds. Oh,
Okay.
yeah.
Okay.
Uh, okay. Beautiful light next to your face.
Yeah, no, so it's from guy.
Okay, so we are going to speak more about the third, fourth, and fifth regulatory system, and we'll be getting to the finish. So about an hour more, and we will be done with all of this. So let's continue. The third regulatory system.
Okay, so the first one, the regulator, is about the autonomic nervous system and the lipodemia phenomenon. Um, this regular, I always say this regulator is mostly connected with the autonomic nervous system. Is important for us because autonomic nervous system can create many of patient symptoms. We have in this regulator, we have studied the system the most, both in research and dissections. So this is the best understood regulator in our work. In Poland, sometimes we say this is a 21st century regulator because many patients today shows a problem in this area. So um, uh, this regulator is special because it depends of a lot of the patient themselves. So many outside the factors can change this system works, and we will discuss about this factor later. Um, this and we, this discovery of the tissue was quite sensational because we always said that the Radosław Składowski was probably one of the first researchers of the world who connected patient symptoms with exact tissue causing them, and also show how this tissue is linked to the nervous system. Um, Before we go deeper in this topic, we need to quickly understand how this autonomic nervous system work. This is the important because if you will be know how it work, it will be better for us. It will be easier for us to understand the patient problem. So we know that the autonomic nervous system has two branches, sympathetic and parasympathetic, and sympathetic creates terms creates sympathetic when the sympathetic branch is getting higher, we have our body creates terms to fight or flight response. So we are steady for action, we keep active, we expend energy. So our body creates terms to fight or escape. So our heart rate is higher. So our muscle getting high tension. Our blood tension is getting higher, increase. So and most important to remember, when the sympathetic branch is higher, people who are living in the sympathetic branch is lower, higher, they have a problem with the healing. So they can get they don't have a regeneration. They have a problem with the sleeping. So the people in the sympathetic branch, their sympathetic branch is a high stimulus. So they have a problem with healing, and they have a problem with sleeping. So this is the main important things to remember in the sympathetic branch. So, and the parasympathetic branch is responsible for the rest, sleep, digestive, blood from the peripheral parts of the body comes to the center because we need the blood to digest, we regenerate, and hold this stuff. So, and the people are living in the such kind of the swing between the sympathetic and parasympathetic. We always says that the people have a more sympathetic branch increase than parasympathetic. And but if they live in such a thing, there's everything is okay, because when we have a parasympathetic response, when we can achieve the parasympathetic, everything is cool, everything is okay. The problem is always shows when we don't have the parasympathetic, when we can achieve the parasympathetic, and we create some kind of dysautonomy between two branches. So and then it shows the problem. But we'll be speaking about this for a few seconds. So which kind of the factor can stimulate the sympathetic branch? So it can be everything. So high processed food, so chemical stresses, high processed food, a lot of energy drinks, a lot of coffee, a lot of stimulants. This is important. Alcohol in the first moment will be increase the sympathetic branch. Stress, and most important for us to remember, is the pain. Pain of the patient will be increased. The pain of the patient will be increased the sympathetic branch. And emotions. I don't like to speak about emotions are good or bad. We always speak the emotions, because everything is emotions are stirring in the limbic system. In the patient in the stress. They are acting using only the limbic system, not the frontal lobes. And we know which factors are increasing sympathetic branch. So what we can do to getting lower the sympathetic branch? The people always choosing exercises. Long. Somebody take the intensive exercises. Somebody takes the effort long exercises. Alcohol, because when we are drinking a lot, our sympathetic branch is getting down, and we have some parasympathetic. So everything with mindfulness technique, everything with prayer, digestion, sex, because the orgasm is a perfect. The sympathetic and parasympathetic branch are in equal level. Okay, so the people naturally will be looking for this kind of the achievement of the parasympathetic, and they're looking in the rest, mental techniques, and meditation, prayer, sex, digestion. And if you know what sympathetic makes and the parasympathetic makes, we have some kind of the image of our patient. So this patient will be overstimulated. So this patient not living so good, not eating good, he's not exercising, he's living in the lot of stress. And when we are speaking of stress, we are speaking of stress who's during a lot of time. So because when we are have a lot of stress, our body release the cortisol, and the cortisol is in a high level, and it causes a very serious damage and serious illnesses in our body. So when the cortisol is in high level, slows down the tissue healing process. I said it on the beginning, sorry. So we can healing. So if we can healing, we will be speaking about the patient in chronic state. So increase the muscle tone, increase the body damage for oxygen, because the oxygen is a need to increase the muscle tone. Increase release of calcium from the bones, because we need the calcium to make the muscles cramp. And the calcium is very important with the cramp the muscle. Increase the heart rate, increase the blood pressure, increase blood glucose concentration. We always say that in Poland that this is a recipe for illnesses of 21st century, like diabetes, blood hypertension, heart attack, stroke, and death. because high cortisol can lead to these disorders. Causes problems with memory and learning. People in the stress can learn. They have a problem with the learning and the problem with the speaking about the knowledge they already know. They always forget this knowledge. They have a problem with memory. It provokes characteristic displacements of fat tissue deposits. This is important, but it shows how these patients going fat. So they have a problem. They getting displacement fat tissue in area of the head, of the face, and in area of the thorax and the stomach. So there they fat in that way. The fat is localization. The localization of the fat is near the chest and the stomach. There is a thinning of the skin tissue. This is kind of the red one spot, and it tells us about this. The patient lived in the chronic sympathetic state. So because when the people and the patient changes his life and they getting lower the sympathetic branch, this thinning skin tissue is going away. So this is our observation. Stretch marks appear with characteristic pink color. Patient with a high cortisol and higher sympathetic branch have pink color marks, and it provokes the breakdown of tropocollagen. And this is how this people, how this our patient maybe looks like. And the conclusion is that the whole stimulus of the sympathetic branch, it can be lead to the sympathicotony, because we know that in our body has sympathetic fibers are in whole body, but parasympathetic fibers are most located in the center. So the conclusion is that sometimes we have so much sympathetic approach, sympathetic increase, and we don't have response from the parasympathetic branch. And where is no response from parasympathetic branch, that increase sympathetic branch, and we call this sympathicotony. And the sympathicotony is always shows in the lipodynia, subcatonal fascia tissue. And I always say that the lipodynia, always give a definition of the lipodynia, because this definition is the best way to understand which lipodynia is. So it's stripped three-dimensional formation bullied with the main mass into the lower subcutaneous fat tissue, having precisely defined topographic location, showing a specific tissue structure, and richer vascularization and innervation than surrounding subcutaneous fat tissue. Lipodynia has a strong connection to the vegetative nervous system, especially in the sympathetic nervous system, as indicated by the vascular and secretory reflexes generated by the stimulation of the lipodynia. When Składowski observed the lipodynia, he see that this fat tissue is lying superficial, and this tissue has kind of tissue gives a burning, cutting pain. It's the thickness, and he's not moving very well. And he's starting looking for some kind of the repetition of the pathways, as he's starting to draw up on the map, and he creating the maps of the lipodynia. And this we will looking at the slides, the map of lipodynia. First of all, in the first name of the lipodynia was octopus, because when Składowski draw on this human, this lipodynia, he look at this and he's thinking about this octopus, because on the stomach we have a head of octopus, and particular branches of the lipodynia surrounded whole body. So the first name of the lipodynia was the octopus. The octopus is our whole body. So we also have a cephalic lipodynia, and we see the cephalic lipodynia is anchored to the auricula. So the particular branches of the lipodynia are anchored to the auricula. It's a very interesting topic, because it can cause very serious problem with the region of the head, but it can be cause a problem with peripheral structures, like the problem with knee or leg, something like that. So the next slide, we have some autonomic nervous system clock. It's a very important, because for the second we'll be speaking about the pain diagnosis, and we must understand why the patient has a pain about special moment. So autonomic nervous clock. So we are looking at this clock, and we have 3 phases. For 12 to 8, we have a common phases. So this is mixed phases, because we have some parasympathetic and sympathetic branches. They mix together. From 8 to 4 o'clock, we have some parasympathetic branch. Yes, so we have a resting at this time, and from and from 12, we have some sympathetic branch. And for us, and from the point of the therapy, and from the point of view from the problem patients, is important for us a moment when the branches changes. So from the parasympathetic to sympathetic. So this is approximately something between 3 or 5, 3 or 4. So when these branches are changes, it's a very stressful time for our body, and our body releases a lot of cortisol. So, and now, if you are going to the pain diagnosis, so the pain diagnosis in this regulator will be speaking about this in this way, that the patient has most biggest symptoms where he do nothing, where he functional in the whole day, and he doesn't feel the pain. And when he's going to the home, when he's going to the bed, when he wants to fall asleep, and he's not moving, the pain shows. And the pain is so annoying. He must starting make the movements. He must starting the moving, because when he's moving, the pain go away. So in the third regulator, pains will be shown when we're not moving, when we are lying, because the best time without moving is time when we're sleeping. So this patient, and when the parasympathetic and sympathetic branch are changes. So this is very stressful time for our organism, for our body. That's why the patient will be, when will be asking him, when do you feel the pain? He always will be saying, I can't sleep at night. The pain is waking up me. I must stand up. I must move the head, move the arm, move the leg, and do something, make some move. Because when I make some move, the pains go away. Then I go to the bed, and I go to sleep. And after a moment, the pains occurs. The pain shows again. So the pain will be always shows up when we are not moving, when we are lying, when we are sleeping. And the pain diagnosis, the patient always will be have problems with problems with sleeping. This is the most important thing in the medical interview when you have pay attention of this. When we are working with lipodema, the patient will be feel stabbing, cutting, burning, pain. This is important, and when we are working in this regulator, we must hold this tissue to then the patient used to with the stimulus. So when the burning cuttings go away. So main the techniques we are using of this regulator is a manual technique. Sometimes we use tools technique, but the first of our choice is a technique we call grasp. This is we will see on this slides. We are grabbing the fat tissue, subcutaneous tissue, and holding until the patient will be say to us, "I'm used to the stimulus what you give me." And now examples from the office, from our clinics. So this is the patient of the Christopher, I remember that. And the patient has a lot of problem, metabolism problem, and the lumbar vertebra problem. And we see on the slide on the left, this is before therapy. And this is a slide in the right after therapy. Christopher used only one technique. He grabs lipodema on the stomach, and he's working with lipodema on the stomach. And it was one technique, and the pain go away. The patient feel the better. And the movement, the range of movement of this person is better. We see on this picture. Next one is a very interesting because I don't say already. Everybody knows the illness we call the frozen shoulder. And we know that in frozen shoulder is a very difficult illness to treatment. So in the physiotherapy, there is a lot of approach to this disorder, but most of them are not successful. Yeah, so sometimes patient must waiting. Doctor says that after 2 years it's go away. But this is not true. I know that the patient they can illness for many years of this disorder. Frozen shoulder has two phases. Warm phases and the cold phases. Warm phases is dedicated to lipodema phenomenon, and the lipodema is the game changer when the patient is in the phase. And the second phase is we call the cold phases, and this is a phase from the first and second regulator and other structures. But when we catch the patient the warm phase, we can treat him very easily using this technique. And this is on the slide. We have a patient from Olga again. The patient has a frozen shoulder. On the movie, we see that he can't move his hand. Yeah, the range of movement is very pure at this moment. And Olga, he is telling, "Oh my God, my hand! I feel the pain." And Olga makes the only one procedure, make the lipodema over the head and the stomach probably. And patient after this one visit and one therapy, his range of movement is like on this film. It's quite amazing. It's quite very extra internal rotation is very important, because in the frozen shoulder there's a lot of problems with that, and we see the range of movement is excellent. So it shows how the lipodemia can knowing our movement and can cause many damage in our body. Okay. Next one is from dissections, and I give the speak to Christopher because Christopher is a main specialist about dissections and the study in our company. So Christopher, the stage is yours.
Okay. Okay, thank you. Yes, the lipodenias is something which we are really interested in, and we do some research, scientific research about those structures and some dissections. And this is what I would like to show you now. I would like you to show to you this structure. Unfortunately, during the webinar, we don't have a possibility to practice. So we always want people to palpate the structure, to feel the structure on themselves. We have no possibility in this form. So you, please take a look at the movies from the dissections. So what we can see here, I will launch a pointer. Okay. So in the picture, we can see. Wait a second. I have to. Yeah, I don't want you to hear this voice. I want you to hear my voice. Give me a second. Okay. So you can see the shoulder, the posterior part of the shoulder, and here there will be an area of a triceps brachii again. And we palpate via dissections during dissections exactly the same like we look for the lipodenias on the living person. And what we can find the parts, the areas of the subcutaneous tissue which are condensed, more tight, more condensed, that we have, that it creates one whole structures. There's one here, and you can pay attention at this adhesion to the skin. This is also typical for lipodenias, that the condensations make the adhesions to the skin. This is the second part of lipodenia. So we have the second one, and in a few seconds here near the elbow joint, you will be able to see. Okay, it's here. This is the normal fat. So this is how the fat tissue, adipose tissue, looks like. It's there are many separate parts of the fat tissue, so it looks totally different than the lipodenia. Lipodenia and as a whole condensations with exactly thin borders, and the normal fat as a just let's call it small drops of fat tissue. This is the physiological normal fat tissue. So this was a movie and a few pictures, few photographs from our research. We recently we've been to France and to Portugal on the congresses, anatomical congresses, to show those structures, to discuss about those structures with the whole anatomical world. So we have a lot of different experiences about it, and here you can see the pictures from our pilot studies. Here we can see the posterior part of the thigh, and actually posterior medial part of the thigh, and we can see one lipodenia here and the second one here. So we can easily see the condensations on the of the fat tissue. Here we can see just the close up, so we can see how the fat tissue, you can see the lipodenia here. Okay, it's easily seen that it has a different structure. It penetrates deeper. It penetrates deeper to the facial level, and it attaches to facial lata. And in the upper limb, this is my favorite picture here. In the upper limb, you can also see the lipodenias. This is the right shoulder, the posterior part of the right shoulder, and And you can see the parts of the lipodynias. They are here is the elbow joint, so we can see the lateral part of the posterior lateral part of the lipodynias, and they all come together to the scapula, to the fascia. So this is how it looks like, and our very recent work with ultrasound imaging, and we can recognize that lipodynias are seen also in ultrasound imaging. This is one of the this is a part of our big scientific project, actually. So what can we see in the cross-section ultrasound imaging? Where are we? We are again in the posterior medial part of the thigh, and while looking for the lipodynia, we can find out that this is a proximal part of the thigh. This middle picture is the central part of the thigh, and this is the distal part of the thigh. And on every each level, we can see the structure which is shaped like a canal, like structured. Take a look that it is closed from every each side by the connective tissue septum, connective tissue membrane, and this is how the lipodynia can look in the this is how the lipodynia can look in the ultrasound imaging. So this is this picture here. uh, what is this black circle in the middle? Sometimes during dissections we can find that there are uh, veins within the lipodynia, within this condensation, and this is this case. This is a great saphenous vein, and we can see that the great saphenous vein is like closed inside the fat tissue structure, the fat tissue condensation. So please remember these pictures and take a look again here. So we were exactly here on this part of lipodynia. So this is how it looks like during the dissections. We still do a lot of projects connected with the lipodynias. We are waiting for our possibilities of the publications. We just have to do much work for this. We need a histological studies also, but we would be really glad to meet you at one of the congresses we go for, and we discuss the method and the structures with the scientists from the world. So maybe we can meet there. And this is all if it's going about the third regulatory system, and the patients we who have the patients who mm, are very stressed, who are easy to stress, who don't live well, who don't sleep well, who don't eat well, who don't move in the proper way. We call them the type 3, so the fire patients. The fire is connected mostly with the reaction for the pain, because the therapy of lipodynias can be quite painful. So now let's stop for a minute and let's sum up those three regulatory systems. So if it's going about the first regulatory system, again, we speak about the fascia, about the muscles, about the ligaments, the joints, the attachments, and we say about the mechanical transmission of the forces and the adaptations to this transmission. So we spoke about the color beams. We spoke about different types of adaptation to the overload. The pain comes from the irritation of the mechanoreceptors, so we can call it a typical receptive pain. So during the movement, the muscle and the fascia starts to irritate the nerve endings. The nerve endings give us a pain, and the patient feels pain well localized, and patient cannot continue the movement. And we do proper therapy. In the second regulatory system, patients feel the pain after the period of stagnation. So I don't feel pain while sitting. I don't feel pain while lying. But after the 2, 3, 4 hours of spending time in one position, I feel after the initiation of the movement, I feel pain. But while the muscle pump starts working and the deposit of the blood is pushed out from the compartment, we can feel better. In third regulators, so autonomic and lipodynamics, patients feel the pain mostly while not moving. So it's opposite to the second regulator. Okay, in second regulator, I can sit, I can lie down. In the third regulator, I cannot sit, I cannot lie down, because while I'm stop moving, I feel the pain. So the patients who say that they cannot drive because they feel the pain while sitting, and of course the assessment with the patients. So this is what Kuba told you. So the stress, the diet, how does our patient sleep, and everything. So every each factor which can irritate the sympathetic part of the autonomic nervous system, it can cause a pain in lipodynamics. And now the fourth regulator, synkinetic chains. This is a very broad, actually, this is the broadest area of our study and of our interest. We teach a lot about this regulator. It's quite complicated. And once again, of course, we don't have few days here to teach you about synkinetic chains, but we would like you to understand the idea, and this will be all, and we will get to the fifth regulatory system. So what are the synkin? Let's begin with what synkinetic chains are not. So the synkinetic chains, probably you know some models of therapy connected with the some kind of muscle chains, muscle trains. For example, anatomy trains of from Tom Mayers, the facial concepts like the facial manipulation described by Luigi Stecco. So we have many different models of therapy, and those models use a global way of thinking and analyzing the human body, human's locomotor system. And those methods are good. I we would like to say that we will show you a bit different approach, but the methods I spoke before, they are quite good, and we are not opposite to them. Absolutely not. So what are synkinetic chains? The idea of synkinetic chains is that it can be a group of muscles, and this group of muscles cooperate, those muscles cooperate with each other during some kind of stereotypical movement. And this is our movement which is physiological, and nobody has ever taught us how to do this movement. What kind of movements I'm thinking about? For example, walking. Nobody has never ever taught anybody how to walk. If you are healthy people, if we are healthy children having which are who are about 1 years old, we start learning how to walk, and nobody teaches us. The same with the breathing. Nobody tells to the newborn child how the child should take its first breath after the birth. Okay, uh, we do not have to think how we sit. We do not have to think how we hold the standing position. We don't have to think what muscles we should activate to start speaking, for example. Please pay attention. There are totally many muscles I'm using right now while talking to you, and I'm not thinking about what muscle I have to use is the for the any word. Okay, it's automatic. So in fourth regulator, we say that we have, and it's not a rocket science, it's really well known fact, and this is what I'm talking about now. You can know it a bit from the neurological concepts like NDT Bobat or Voitas concept. So we know that our extrapyramidal system controls the physiological movements, controls the muscles to do physiological movement patterns, like I said, walking, uh, breathing, standing position, or something. And we have those patterns as a code, as a program in our extra pyramidal system. And this is what are the synkinetic chains. So the synkinetic chains, again, group of muscles, the muscles cooperate very strictly with each other during our stereotypical typical activities, uh, controlled by our extrapyramidal system. Just imagine, just remember how complicated function is breathing. While your studies, I'm sure that while you were studying, you were learning about the breathing muscles, what group of muscles help us to breathe in, breathe out, main muscles, additional muscles, and remember now, please remind about all of those group of muscles, and now think that after during every each your breath you are breathing in and you are breathing out, you are using a lot of muscles nobody thinks about, so you don't have to think how to breathe. You're just breathing. Of course, it's autonomic function, that's why you don't have to think about it, but you also don't have to think what muscles should be activated and how we should activate them to make take a breath. I just take a breath and I don't have to think about the muscles because the extrapyramidal system does it. And this is the idea of synkinetic chains, and that's why here it is not possible to make a dissection, for example, because we speak about functional connections, not the structural connections. And this is this concept and this idea. Here you can see the examples of different synkinetic chains. We teach about them during our courses of Pinotherapy, of manual medicine. And you can see, for example, if you pay attention at this green picture on the left, you can see that this two. Okay, so let's take a look at this green one and at this red one. So pay attention that if we connect those muscles together, we see the function of walking person, of the guide. So one limb forward and lower limb also forward, and the opposite limb goes back, and the opposite lower limb also goes back. And so this is the function of guide, and we analyze the group of muscles, and we try to find out if the cooperation between the muscles is proper. How we use it? Usually, oh, I will show you on the slide later. Now, in a big shortcut, I would like to explain to you how can we imagine the pain. What is the pain in the fourth regulator? What will patients tell me if they have problems with coordination of working on different groups of muscles between their themselves. So kinetic dynamic. So this is the patients who feel pain occurring after a long term of fatigue of the disturbed chain. What does it mean? I feel that the longer I walk, the worse is pain. Okay, so the longer I do something, my symptom gets higher. So the chain is getting, let's call it, exhausted. The second example, postural chains, it's the same. The longer I'm in standing position, for example, in the church, during a queue, in the shop, or on the bus station, when while I'm standing, the longer I stay, the more pain I feel. The static from support chain, the longer I sit, the higher pain I can feel. And multi-receptor, it's something very interesting, because the synkinetic chains is something which is highly used by the sportsmen, by the people who move a lot. So the patients sometimes, and I think you may know this, patients sometimes describe their dysfunctions and describe their pain very, very in very difficult way. They have increased sensory experience, so they tell us a story about the pain. It's tingling. They feel a pressure, a vibration. So very different and very wide descriptions of the pain symptoms. This is typical for those patients. And what we do with in this regulator, when we diagnose the pathology in the synkinetic chains, we use the techniques which are pointed, which are aimed to the restoring the proprioception of the patients. So the manipulation and mobilizations technique of the joints, but very, very important, we use manipulations, but of course we know that the manipulation of the joint used itself, it gives only a short-term effect. So we try to put the manipulations of the joints and mobilizations of the joints in a very important context of the whole strategy of therapy. We work with different tissues, with different regulators, and I will show you this in a minute. So there are a lot of techniques, a lot of manipulations, mobilizations. These are only the examples, just to show you how it looks during the course. And manipulation, it may not be something interesting and new for you, but in this right slide you can see the technique we call the short circuit. And this is a technique while we compress two piezoactive points from two different chains. And this is the next project, scientific project, we are conducting here in Poland, uh, uh, just to evaluate this technique. We try to look for the specific points and compress the two of the points at the same time, just to restore the proper coordination of working of the groups of muscles. And this is how it looks like. Difficult regulator, a lot of knowledge. So this is what we wanted to tell you, just to give you an idea of the synkinetic chains, and as the not structural but functional connections between the muscles, between the muscle functions. Of course, there is a lot of kinesiotherapy here, so we do a lot of training with our patients after the passive therapy. It's time for active therapy. And now the last thing, we have 2 hours, 15 minutes long, like I said, about 2 hours and 30 minutes. So the last fifth regulator, it will be very, very, very fast, I can assure you, because the fifth regulator tells us about the skin projective areas phenomenon. So we called it SPA. And actually, the fifth regulator is a collection of clinical observations. And to be clear and honest with you, those observations are not fully understood and explained, but the observations are very, very easy. Radek Składowski observed that sometimes during musculoskeletal disorders or visceral disorders or pain in any part of the body, we can find the areas of the skin that I that are hyper or hyposensitive to a simple stimulus. And this stimulus is something like a pricking. So we just take a few pins, okay, and we stimulate the skin just like this and nothing more. And it should be felt totally normal. But in some cases, during the pathologies, we find that on patients' skin, we can find the skin projective areas. So again, the areas of hypo or hypertension of the skin. We stimulate those parts, those areas of the skin, and sometimes we observe that first of all, patient feels less pain, but it's a short-term effect. Okay, so we will all know the pain gate. So this, of course, is a pain gate. So after the treatment, patients feel much better in the short term effect, but also sometimes we observe that patients, that the organism of the patient is able to regenerate faster, and the process of rehabilitation goes better, and the rest of our treatment is more effective. And that's why I called this regulator some kind of additional one, because the point is just to make our therapy more effective. And I would like only to show you one example of the patients. This is a very spectacular one. This is why I'd like to show you this. This is our patient. She had a big accident. As you can see, the skin was taken off from her forearm, and they had to transplantate the skin. They took it from the thigh, and after the accident, the skin, there was the one thing, but the second thing was the massive fracture of the radial and ulnar bone. This is the 19th of March 2012. Of course, doctors began the first surgical procedures, and here we can see the picture from the April 14th of April. And what can we see? The patient after the surgeries, and we can see uh, two fracture zones, the one in the ulnar bone and the second one in the radial bone. And what we do now, we just wait for the regeneration of the bones. But unfortunately, the regeneration does not appear. So in June, we can see again two two fractures, two zones of the fracture, one here and one here, and what? And unfortunately, we cannot see any symptoms of regeneration of the bones. So the doctors are a bit nervous, and they get really seriously um nervous, let's say, in August, because in August we have about approximately 5 months after the fracture, after the accident. So we have about 20 weeks, and we can still clearly see the zones of the fracture. There is no regeneration of the bones. So what does it mean for the patient, and what does it mean for doctors? That the bones are not regenerating, and nobody wants to reoperate this area because of the replantated skin, so they don't want to do reoperation. So the prognosis for the patient is that maybe doctors will have to take off the forearm, so the amputation of the forearm, because it's not possible to live with proper function with two not regenerated bones. And about August or September, in August, September, the patient came to our friend and they started the general rehabilitation. And during this general rehabilitation, they were stimulating, just like I showed you, they were stimulating the skin where they could. So not in the places of the structure, but on the arm, a bit on the neck, just to stimulate the skin, to stimulate the blood circulation, and they were finding the skin projective areas I told you about. And the next picture comes from the October, and in October we can see the first picture since March 2012, where the regeneration of the bones started. And in December, we can see that there is a almost the bones are almost regenerated. So there was no amputation on of this hand, of this arm. Here you can see. I will also switch off the sound. Okay, and you can see the patient. You can see the patient with her forearm. We can see the big scar, and we can see that the function of the, the arm, the elbow joint, the forearm is the upper limb at all is very, very good. There was no amputation. So we can sum it up that after almost 6 months without any regeneration potential, after starting rehabilitation with our method, uh, it just helped these patients. We have many more examples, of course. None of they are not every each example is so spectacular, of course. But this is how it looks like. So we try to stimulate the patient, and this is the hypothesis that if the body reacts with the skin projective areas to the pathology, to the bone fracture, to the pain of the knee joint or the sciatica. So maybe when we find the skin projective areas and we stimulate them, maybe we can have an impact and influence to remove the pathology. Like I said, this is the additional knowledge, so we use many tools, and after this, sometimes we give the homework to our patients, and they are stimulating their skin, at least to get a blood flow and circulation better. This is how the technique looks like, so nothing special. And this is really simple. That's why we can give it to our patients as a homework. And that's how the 5 regulatory systems look like on this very basic level. So if I had to sum it up, I would tell you that five regulatory systems. Like I said, there's nothing mystical here. We base on anatomy, on physiology, pathophysiology, and we try to find out what kind of tissues, what kind of processes are involved into patient's disorder, patient's pain. And this is how we think about it. So again, the 5 regulators, it's just a clever trick. I think it's clever trick just to take a new look at our patient. Remember that the author of the method is orthopedist, so Radek always was always using this method while working with the locomotor system, the dysfunctions of the locomotor system, and this is what the method was created for. That's why in Poland the method is gaining popularity around the physiotherapists, manual therapists, chiropractors, osteopaths, and we also teach medical doctors from different professions. uh, so this is how it looks like. We have to remember about our inner diagnostic system. So remember that we always during our courses we teach palpation, we teach about this diagnosis, this assessment with patient, and asking when do you feel the pain, because you know now that every each regulator will generate, every each tissue can generate totally different objective pain syndromes. We call it label pain, and this typology, so the short characteristics of the patients, which helps us in good, in providing a good therapy. So you saw the slide before. You saw this slide before. So again, there are a lot of techniques we use in different regulatory systems. And this is very important to connect the diagnosis with the proper technique, with the proper tissue. And this is what we teach. If you are interested in any of our courses or knowledge, you would like to know more, not know more, but you want to know more knowledge, you can find us on our social media. Of course, you can write to us. You can send an email or anything you want. So feel free to ask, feel free to follow us. And in my own name, and I think also that in Kuba's name, we thank you for your attention. Thank you for your attention. We know that there was such a long time, 2 hours and a half, just like I said, 4 minutes to 9:30. So this is how the basics of the five regulatory system look like. Remember also, if you want to send us an email, so you have on the chat you can see our English address. It has PL ending, but it's English address. So office FRSc.pl. Uh, and if you don't have any questions right now, uh, we just thank you for the attention, and we hope to see you maybe in your country, maybe in Poland during the courses. We are always open for cooperation, and if it's going about the courses, but also if it's going about the research, we try to do research and we do it. So we also look for the cooperation in that. Kuba, what do you want to say to the people in the very end?
Thank you for your attention, and I hope you see you something somewhere in Europe on the courses. So have a good night.
Okay, so thank you very much. Have a good night. And remember about the retransmission of the webinar. So the whole webinar will be on our YouTube channel, and we will send you a link reminder in your emails. Thank you very, very much for your attention, and good night.
Good night.